Good afternoon, one and all.
Hello, one and all. This video describes
So
an
my
innovative
innovation
technique of
is
tuck
about
SFIOL developed
an
at our
SFIOL
institute.
that is called
As
a
a
tuck
VR,
SFIOL. Can I have the sound, please? Yeah. My name is Dr. DHAIVAT SHAH. Yeah. So
hello, one and all.
sound is on.
This video describes an
Sound.
innovative technique of tuck SFIOL developed at our institute. As a VR surgeon, I see all these kinds of subluxated IOLs and dislocated lenses in my routine OPD. The main aim for me in these cases is removal of the cataract or IOL, clearing the vitreous and placing a secondary IOL. So various techniques like the Yamane, the flange, the 4-point and of course the old-fashioned iris claws have been described in literature. So what is actually an ideal good secondary intraocular lens? Let me show you my technique. So basically I make two holes at 1.5 mm from the limbus, make two adjacent tunnels, take a 3-piece IOL, place it inside and remove the haptics from the hole and place it inside the tunnels. Sounds very simple, right? Yeah, it definitely is. And along with simplicity, it is also cost effective. So let me run you through one of the cases. So this is a case of a 50-year-old male who had a blood trauma and a secondary subluxated cataract. So here, 3 localized peritomies have been made and a 25 gauge system is used. Now, like in the routine SICS, we make a tunnel and place some visco inside, and once the endothelium is well coated, we remove the nucleus through a wire vectis. Once this is done, the most important part of this technique is doing a good anterior and a core vitrectomy. And once the core vitrectomy is done, I mandatorily check the periphery for any kind of breaks. Now, to lay the background for a secondary IOL, two holes are made at a distance of 1.5 mm away from the limbus at 3 and 9 position, that is, just outside the root of the iris. Now, two partial thickness tunnels are made with the help of a normal crescent blade. Once these tunnels are made, an X-nit needle is taken from one of the holes and the end of the X-nit needle is exteriorized through the superior scleral tunnel. Now, the leading haptic of the 3-piece IOL is inserted inside the needle and that is exteriorized from one of the ends. Now, while exteriorizing, you see the yellow mark. That is something that is called the silicon stopper and it will prevent the lens from going back inside. For the other side, the trailing haptic is fed to a max grip forceps and it is exteriorized from the other side. Once both the sides are exteriorized, the haptics are actually snugly fitted or tucked inside the partial thickness scleral flaps. As you can see, the IOL is beautifully stable. The beauty of this technique is that it does not require a suture or a glue to fix the intraocular lens. As we see here, the post-op results are very pleasing in terms of visual acuity, stability of lens, and minimal pigmentation. To assess the nature of the haptic, at 1 month follow-up, we did an ASOCT at the level of the haptics and we could see the haptics very nicely buried at 2/3 of the scleral depth. On the UBM, we can see that the lens is nearly in its physiological positions and there is a sufficient distance from the iris, hence the chance of a post-op pupillary block is minimal. So does our technique fit in the criteria for a good SFIOL? Definitely yes, it does. Certain complications that can happen are haptic protrusion, pigmentation over the lens surface and tilting of the lens. So till date we have done more than 260 procedures and our complication rate for the stuck SFIOL technique is less than 4%. So I believe this is a brilliant, cost-effective and easy to learn technique for secondary IOLs. Thank you very much for watching.
Thank you. Hi.
Comments or questions first?
Comments and questions.
Right.
Comments, questions, queries.
Dr. Shah, it's
Yes, sir.
nice technique, but
Thank you.
uh, what what is the
Oh.
rate of the decentration in this?
So the rate of decentration actually depends if you have made exactly, if you have made it at 1.5, the rate of decentration is less than 2%. But sometimes what happens, because we are in a hurry, we don't measure the distance of 1.5 from the limbus. And that is actually the reason for decentration that we actually saw in a 3-month UBM that we did post-op. So we have done around 250 cases, and now we have realized that if you are putting the haptics at an appropriate distance, the lens does not get decentered.
Okay, and regarding the extrusion of this haptic,
Extrusion, yes. So if the scleral tunnels that we made, the scleral tunnels have to be at least 2/3, like we do in buckles. If they are at a 1/3 length, the rate of extrusion is a little more. If they are at a 2/3 length, so that we saw on the ASOCT, and then we realized. So if yes,
Okay,
is it do you feel
John,
is it a better
John, you
Sorry,
can
better
get
compared to
ready here.
Yamane?
sorry,
Is it-
I feel it is definitely better than the Yamane. Two reasons for that. One is decentration, and second, I used to do a lot of Yamane as a VR surgeon. I felt at 3 months, 6 months, 9 months, the patient was a little uncomfortable with that, bulge of the haptic, and he used to say, "Dikh acha raha hai, par maza nahi aa raha hai." So that was So then with this technique, now I have a 3.5 year follow up. We have published this paper also, and it is well accepted now. So I am very happy with the results.
Thank you.
So as a VR surgeon, sir, I really prefer, but you can go. So my main concern is I want to check periphery in all cases, and if there is a lesion, as the sir would understand, I would want to laser it on table. But you can get away with the vitrectomy. You can do an anterior, and you can still do this technique.
Thank you, judges.
Just one question.
Yeah, sure, sir.
What was the actual innovation in it?
So the XNIT needle is made by Arvind, but they introduce XNIT from both sides, and they have made a different kind of a flap that has been described in that technique. I have made a different flap here, and the other side I'm not using an XNIT, I'm using a max grip. So you cannot say it is a completely a new technique. It's a modification
new
of
technique, but
yes,
not exactly innovation.
yes. It's a modification of an innovation. That is it.
Let us move to the next paper.
Thank you very
John,
much.
Thank you very much.